to cars, white girls of the north, file past one, fire and one. They are the fabled lambs of Sunday ham, the HS norm.
Almost everyone who has a limb amputated experiences what is commonly referred to as a phantom limb, the vivid impression that the limb is not only still present but also very painful. In many cases, the limb feels as though it is shorter and in an uncomfortably distorted position. Such information begs the question, how can one possibly experience pain in a body part that no longer exists? Unfortunately, there is not one concrete answer, but there are three explanations that are widely accepted to be true. Following the loss of a limb, between 90 and 98% of all patients experience a vivid phantom. Studies show that the incidence may be higher following a traumatic loss or if there has been a pre-existing painful condition in the limb itself. In regards to onset, phantoms appear immediately in approximately 75% of cases as soon as the anesthetic wears off and the patient is conscious. As far as duration goes, in approximately 70% of the cases, the phantom is present initially for a few days or weeks, then gradually fades from consciousness. Although phantoms are most commonly reported after amputation of an arm or leg, they have also been reported following amputation of the breast or parts of the face, and patients often note that the phantom maintains a habitual posture, for example, flexed at the elbow with the forearm pronated. As previously mentioned, there are three widely accepted theories used to explain phantom limb syndrome, the first of which, simply put, is memory of previous limb pain. It is believed by some that after a particular limb becomes damaged beyond repair, the brain becomes so adapted to sensing the pain that, even after the limb has been amputated, it continues to do so. Another predominant theory for phantom limb centers on irritation in the severed nerve endings that subsequently evolve after amputation. Such nerve endings are referred to as neuromas, and it is believed that after amputation, many neuromas are terminated at the residual limb. After inflammation arises, the neuromas are believed to send anomalous signals to the brain, which, essentially being gibberish, are interpreted as pain signals. Last but not least, the third theory revolves around the somatosensory system, which deals with the ability of the nervous system to bring signals from the periphery to the central nervous system via pathways through the spinal cord, brainstem, and thalamic nuclei, whether it be to deal with the perception of touch, pain, movement, etc. The following picture depicts how the cortex is anatomically divided. It's important to note that the representation of the face lies adjacent to the representation of the hand and arm, as many believe this is a key factor in explaining phantom limb syndrome. Ramachandran, a famous researcher on the subject, reasoned that the syndrome can be a result of cross-wiring in the cortex that receives input from the limbs and body, because while the input from extremities comes into the cortex in an ordered fashion, if someone were to lose their right hand, for example, they may have the feelings of a phantom as a result of the input that would normally go from their hand to the left cortex being stopped. Instead, the areas in the cortex that are near to the ones of the hand will take over, or remap the region that no longer has input. Because the main cause of phantom limb syndrome is still unclear, it is very difficult to treat. Doctors prescribe antidepressants and anticonvulsants, which minimize the transmission of pain signals. However, there is an increasingly popular form of therapy that amputees use known as a mirror box, invented by Ramachandran to help alleviate phantom limb pain, a mirror box with both created and demonstrated in the following video. As you can see, a mirror box is created by splitting a box in half with a single-sided mirror facing in the direction of a patient's good hand, while the amputated limb is placed in the other side. Looking straight on, it looks as though nothing is happening. However, when the patient views the device at an angle that favors the strong side, while making mirror symmetric movements with his hand, the reflected image makes it appear as though the phantom limb is also moving. Such artificial feedback serves two purposes. It allows the patient to move his phantom limb, per se, subsequently providing the opportunity to unclench it from a potentially painful condition. Furthermore, it has been proven that by using a mirror box, the neural network within the brain can start to rewire itself to map its new profile and compensate for the damaged or missing limb. In turn, studies have shown this improves the patient's quality of life as well as currently possible.